Jane, is it working?
It says that it is live on Facebook right now.
Okay, great. Okay, that's what I see too. So let me go here and see what we, so welcome everyone to All4Cure's Journal Club. We are very fortunate to be joined by Professor Francesco Moira, who is an assistant professor at the University of Miami, just moved there from Memorial Sloan Kettering. He's a part of a large research group led by Ola Landgren, and is an expert in the genomics of myeloma, and has published a very interesting paper that caught our attention now from about a month ago, and has very kindly agreed to present to our group. So, so with no further ado, let me introduce Francesco. Thank you very much for joining, Francesco.
Yeah, thank you. Thank you for hosting me.
Yeah, and then I think you can go ahead and share your screen if you'd like to just provide an overview of your paper and your work.
So, can you see my slides or?
Yep, perfect. Thank you.
The entire slide or? Yeah, okay. So, yeah, thank you for this invitation. It's always nice to interact and talk with nice organizations like yours. We work a lot on whole genome sequencing. That is not the technology that everybody uses, and the reason is that it's extremely expensive. But that's not just the only problem. The main problem is also extremely difficult to analyze the data. So only few centers across the world are working extensively on whole genome sequencing, and in particular multiple myeloma, very few institutions have provided interesting data or deep data on whole genome sequencing, and we are enough lucky to be one of them. So the study that I've been asked to present is a recent study published on Nature Communication titled Accelerated Single Cell Metastatic Seeding in Relapse Multiple Myeloma. And I think it's introduced some important concept that might have some relevance in the future, in particular also in terms of treatment. So obviously, what is multiple myeloma? I think everyone knows here what is multiple myeloma, and what makes multiple myeloma particularly interesting from a biological perspective is that we have such a heterogeneous clinical presentations. So you have patients with many different clinical combination of symptoms and lesions, which usually underlying different biology. So the fact that certain patients got kidney failure and some patients have a lytic lesion and a fracture, it's probably due to the different disease and different behavior of the disease due to different alteration at the DNA level most of the time. So we are trying to investigate this as many others in oncology. And if we just look at the total number of mutations, without any mutations in any part of the DNA, which is composed by 3 billion units, we have that multiple myeloma is kind of in the middle between the solid tumors and hematological cancer. It's kind of on the average. And
so Francesco, can I just dive in there and just ask you a question, just to make sure thank you. Make sure people understand what this is referring to. So it would be a fair statement to say that every cancer is a consequence of mutations, and there are mutations and alteration in the DNA. And if you were to look at the number of mutations that occur in a cancer cell, there will be kind of broad differences among cancers in the number of mutations in each cancer. And what you're showing here is a graph that kind of highlights, okay, in general, how many mutations are found when you're looking a cancer that's a lung cancer versus a breast cancer versus a multiple myeloma.
That's right.
Yeah, and here you're showing that, you know, there are some cancers that are known to have fantastically high numbers of mutations, like melanoma, skin can, you know, this terrible skin cancer, or lung cancer in patients who have a background in smoking. On the opposite end are, you know, cancers that are associated with relatively few mutations, some of the acute myeloid leukemias and stuff like that. And what you're describing here is, if you look at myeloma in the context of every other cancer, as you've just said, it's kind of in the middle, sitting in the middle.
Yeah, and so the idea is that when you say total number of mutations as shown in this plot is it's like a sort of a big box with many, many mutations, but the causes of these mutations might be different. So let's dive a bit into this concept, which is the key concept to understand our paper. So when you have a cancer, the cancer is composed by millions of cells, and each cells share within each other what we call drivers, like translocation 1114 or 414. Those aberrations that make multiple myeloma happen, because without those, multiple myeloma doesn't start, are present in all cells. So these are what we call the drivers. And multiple myeloma, as any other cancers, have a certain catalog of drivers that we are trying to better understand. It's still unclear exactly how many drivers and which alterations are required to develop multiple myeloma. But together with this, we have also a lot of other alterations that we call are neutral or passenger. So means that you may have one mutation on an important gene like KRAS, like in these slides is pointed in with the red stars, is like one mutation in KRAS, and you may have 100 other mutations that we call passengers across the DNA that doesn't have any effect. So mutations are acquired now by myself. If I went outside on the skin and my skin is exposed to the sun, they get mutations. So mutation doesn't mean necessarily bad or cancer. Human beings, tigers, dolphins, any living creature acquire mutations over time, spontaneously. These are part of our evolution. People got red hair because at a certain point, someone got the mutations that make the red hair. So mutations are also good, but sometimes are bad. So obviously, we care about the driver mutations to find a cure for multiple myeloma, but we can use the other mutations to understand which are the source of these mutations. Obviously, multiple myeloma is not exposed to the sun, but you can think about 1,000 mutations, just to make up a number, and these mutations are caused by different processes. Let's say 3 processes, process A, process B, and process C. And when we sequence our tumor, we can divide using mathematical models that are extremely complicated. But just to let you know, we have the knowledge to divide all these mutations in groups and say, those mutations were caused by smoking, these mutations were caused by UV light, these mutations are caused by aging, these mutations are caused by a deficit in DNA repair. And we also are able to time these events. So we can, for example, understand if a process was active, for example, many, many years before multiple myeloma. So you have, for example, the process C is account 25% of the entire mutation of this hypothetical cancer, but those mutations were acquired many, many years ago. So they're probably not really important for the cancer phenotype and clinical presentation. Process B has much less mutations, but as you can see, it's very close to the diagnosis. So it means that it's not the amount of mutations, but also the timeline and the history of these mutations that matter. And in multiple myeloma, we know that these matter particularly because we have 2 processes. One is AID, which is a germinal center process for the B cell development. All the B cells that work in our immune system needs AID. And the other one is ApoBec, which is still obscure in its function. So we have AID act as a process C in multiple myeloma, so it stops at a certain point. And ApoBec start in process is like process B. So it's important in the progression from asymptomatic multiple myeloma, precursor, and gas and smoldering to multiple myeloma, but also at relapse. ApoBec is still active, it's still ongoing. So you just can keep acquiring mutations.
So Francesco, can I ask you something about that? Just because I'm want to make sure I understand. So as you've said, every B cell as it's making its own immunoglobulin will undergo rearrangement in the lymph nodes. That's process C. Is that correct?
Yes. Yes.
And now, so that's every B cell that we have will undergo those kinds of changes as part of the normal course of B cell development. Is that true?
Yeah, the one that are exposed to the antigens, as you know, it's a little bit more complicated than that. But yes, theoretically, all B cells can have this process.
And but process B, as you're showing here, would be a process. Would that be a process that everyone goes through at some point, or would that be
90% of multiple myeloma?
But how about somebody that doesn't get myeloma? Does everybody have that?
No.
Okay, so process B is kind of a myeloma.
I mean, this process can also be in colorectal cancer, in breast cancer.
I see.
Actually, the same process that we see in multiple myeloma is always late and is always associated with progression, not just in multiple myeloma, but also in solid cancers. So it's kind of, in multiple myeloma is particularly frequent. Let's say that in solid cancer, you have 20%, 30%. In multiple myeloma is 80, 90%.
Thank you. And then would it be fair for me to also assume that when you're showing this tree of cells, when somebody gets myeloma, and I have myeloma, so I think about this a lot, does that mean that that these processes are kind of ultimately derived by a single cell that went from being a normal cell and then developed one of these originating mutations? Everything's downstream of that single event?
Yes, so the answer is yes. I will provide data also more on the relapse settings, why a single cell is the only explanation for relapse. But in general, in all cancer, the model that we are working on, the assumption is that you have these waves of selection where you have one single cell you transform, you start to expand, generate multiple different cells, and one of these daughter cells will develop an additional driver, and so we'll expand from single and take the dominance. Like it's exactly like Darwinian selection, like the strongest win, and it's a long run. So we don't have time to discuss this today, but in our other paper that was published very close to this one, Nature Communication as well, we actually time multiple myeloma initiation in most of the patients 40 years before. So if you got multiple myeloma at 60, probably your first cell was transformed when you were 20 or so.
Wow.
That's our estimation. But obviously, this is a mathematical estimation, so we might be wrong about the decades, but still would means 30 years before your diagnosis.
Wow, thank you.
Yes, so I mentioned the mathematical model through which we can differentiate or divide mutation in process ABC in like schematic way. And you should think as each cells have this unique repertoire of mutations, which we call mutational signatures. We can deconvolute these signatures. Here it's a bit complicated, but just because there are many figures in our papers and also in this presentation, these are kind of a code. It's just like a catalog. The way in which we classify mutations, we divide them in 96 different classes. And we use that as an actual barcode. So each tumor has its own barcode. So we can deconvolute the signal. These are like a study that is kind of pretty intuitive when we talk about signatures. So each cancer has its own signatures. The composition of signatures make the tumor profile. So this one is the total number of all mutations in multiple myeloma in our cohort of 52 patients. So we can deconvolute this. We can, divide and extract these signatures. And each signature represents a component. So it's like ABC. When I presented before ABC, like the pie with each slide ABC, those ABC are the mutational process, and each signature is a mutational process. So that's the paper that I think it's the easiest way to understand. When you think about mutational process, everyone think about the big killer, which is lung cancer. 1 million of people die I think more than 1 million die every year. And the fact that they got more cancer is because smoke introduced mutations. And people using this barcoding system, this mutational signature, were actually able to identify these mutations. So this barcode, like signature 4, is exactly the same mutations that was found in patients with lung cancer and smoke, was actually the same mutation that you can identify if you expose cell lines in a wet lab, to benzopyrene, which is the pro-cancerogenic component in smoking. So that's kind of the proof of principle that this barcoding that we extract in a mathematical way is not just an exercise of genomic geeks that create, papers or want to publish, and actually correspond exactly to what you can find in vitro, and which means that we are able to divide all the mutations in ABC, as I mentioned in one of my first slides. So that's what we did in multiple myeloma. So if you think about multiple myeloma, we have 8 main, in this first core that we analyzed in this paper where we timed the events, which is not accelerated, we found these 8 signatures. And we don't have time to go through them, but I just want to focus on this one. So these signatures that has never been reported before by like solid cancer people that usually are more advanced compared to hematological cancer because they have more funds. It's like a big killer, so there is more also activity there compared to us. But still, this signature has never been reported, and we wonder why. It's like an artifact, is our mistake. Usually, when you find something new, most of the time is your mistake, and it's an artifact, it's not the real data. But what we observe is that actually this barcoding is only present in multiple myeloma patients after transplant. So in samples collected after autologous stem cell transplantations, which is the only treatment in cancer so far where Melphalan is still used. So high-dose Melphalan is used in a few other cancer, but in frontline, multiple myeloma is the only one where it's still used. So we dig into this, we don't have time, but we also validate in vitro, we validate in additional data set. So we have a kind of pretty confident, we are pretty confident this one is the Melphalan signature. So the question is, why not all patients, these black patients are the one exposed to Melphalan? You can see that there are 4 patients that despite they were exposed to Melphalan, so they got transplant, and we got the samples after transplant, we don't have the signature, we don't have the barcoding. So how is it possible? Every time that you expose someone to benzopyrene, you got smoking signatures. Every time that you expose someone to UV light, you get the UV light signature. So why this happened? So that's exactly what we were discussing before. You need the single cell expansion model. So that's kind of the tricky part. If you understand this, from now, everything's gonna be like like kind of smooth. So that's like the real corner, the top of the hill. So if you have hundreds of cells in multiple myeloma after induction, VTD, BRD, KRD, and you have, let's say, 1,000 cells left, and all these cells are exposed to Melphalan. It's like each cell will acquire a unique set of mutations, because Melphalan is not that introduce always the mutations in chromosome 1 position 50 million or chromosome 2 position 1,000. These are random mutations. So if we have 3 billion position in our DNA, the probability that 2 cells exposed to Melphalan had the same barcoding, it's like impossible. So this is why we like the word barcoding, because like in a supermarket, each product has its own barcode. And even if they look like the same, they are not. So that's the concept. If you have that, the progression of multiple myeloma after transplant is not through a single cell selection, but it's through like a bulk effect. Multiple clones progress together. You have Melphalan signatures, you have the barcoding, but it's too low to be detected because we can see only events present in 20% of the cell. So if an event is not shared through 20% of your cells, tumor cells, you can't see it. It's there, but you can't. And we don't have the single cell technology to look at this. But following this concept, if you see the Melphalan signatures, you actually can justify this only if a one single cell with its own barcodes, so its own mutations acquired after the Melphalan exposure, expanded and took the dominance. because each cell has a unique mutations set. So if you have a single cell that got the dominance, you will have that this Melphalan mutation will be clonal, shared by all cells at relapse. If you don't see them, it means that there are probably multiple cells, probably more than 10, that contribute to the progression. So, and
So that's really fascinating, Francesco. So could I ask roughly, if you just had to give a very rough estimate? So you've described, okay, you know, whatever myeloma is present in a patient, they get Melphalan now. Every single myeloma cell will acquire mutations that are introduced by the Melphalan. And the exact complement of mutations that every single cell acquires will be different from every other cell. So it's a way, as you've talked about, of barcoding or uniquely marking every myeloma cell that's left in that patient. And now you can, so roughly how many mutations in a cell on average would be caught in a surviving myeloma cell? Do you have any sense of how many mutations that would be?
So I have a couple of slides after about how many mutations, because obviously you can get 2,000 mutations, but they can be all over the place without never acquiring a real mutations that, you know, what we call a driver mutation. So yeah. That's kind of,
so up to a couple
be
thousand.
Really careful to express this, because, you know, people may read it and say, oh my gosh, I got Melphalan, my tumor got worse. That's not true. We don't know yet. We know that it might get worse, but at the same time, we also know that with the current FDA-approved approaches, most of the patients benefit from transplant. So it's kind of the discussion that is never ended in cancer. Chemo is toxic, but it's what we have. So once we have a better drugs, everybody will be happy to get rid of chemo. Doctors, patients, and I think also company, because chemo is usually cheap. So
right. So I think, yeah, that's really kind of the gist of things, is that this ability to introduce mutations and kill myeloma cells is the big advantage of Melphalan, and it works really well across, you know, many, you know, tons of patients, and it's been used for a long time. And so if you could wipe out all of the myeloma cells with Melphalan, that would be great. You wouldn't, you know, but the concern is that you almost never wipe out every last myeloma cell. And the surviving myeloma cells now have been kind of burdened with an additional set of mutations that have been induced by Melphalan. And could some of those cells have acquired mutations that could be problematic? I guess that's...
Yeah, at the same time, you might also say that even if some residual cells survive, the amount of, you know, the deep depth of response, that's what like most of the clinician most of the good clinician like to discuss about multiple myeloma, like MRD and this kind of concept. You still have to, you know, balance what would be your MRD or your response without. Right. And we know that for some patients, they can get from PR to very good or complete remission with Melphalan. So this study is not aimed to, you know, get Melphalan retired. It's just aimed to introduce some important concept. And obviously, there is always kind of an ethical downside in this. For example, in the smoldering settings, where some groups are treating smoldering patients or patients that have not developed yet multiple myeloma, they might develop, but we don't know, because we don't have a like magic wand or a super accurate score to define who's gonna progress. And some groups are using Melphalan in these patients. So that, I think, it's a bit, let's say, extreme, because you don't have cancer and you expose someone to a toxic treatment. And these mutations are not just acquired by the tumor cells. So when we say Melphalan increase the risk of MDS, increase the risk of solid cancer, this is it. It's
Yeah.
also the number of, and we have like currently studying on this on secondary malignancies after Melphalan, because we discovered the signatures and we want to understand how much the signature impact, for example, an MDS or a leukemia after transplant, that usually, most of the time, it's even worse than a progression, because for the progression now we have treatments. For a secondary AML, most of the time we don't. We don't. So
Thank you.
the last concept that we also found intriguing is, because it's kind of getting to the past, is when you don't see the signatures, it might also be that you reinfuse the cells with your apheresis, because they skip Melphalan in this case. And that's kind of against all the old studies from the French, but we have kind of pretty, confidence that this might happen. So going to the study, which obviously takes a while to introduce all the concept, and also we discuss also about other aspects, but in general, the idea is that if you have a barcoding in each cells, you can use that to understand the evolution of the cells. So let's take this example. This is a very aggressive multiple myeloma relapse with multiple lesions. So the question is, these two lesions, here and here, comes from the same cells or from two different cells? So after Melphalan, this patient is after Melphalan. So after Melphalan, are these two from the same, from the same surviving cell, or are from two different surviving cells? So if there are two different surviving cells, you would have a different barcoding, chemo barcoding, in the two different sites. So if I take a biopsy here and I take a biopsy here, I would have two different barcoding because they are coming from two different cells exposed to Melphalan. If they share the same barcoding, it means that one single cell was responsible for both localization. So that's our study. It's kind of, I'm just showing the slides, but that's the key concept is we took within a program that is currently ongoing at MSK, called Last Wish, where patients donate their body for multiple biopsy after death in many, many cancers. We had these 4 patients that consent to donate their body for research. And Eder Landau and Chris Jacobuzio are the ones that collect and supervise this effort. I just got the genome data. And as you can see from here, these patients are pretty standard multiple myeloma patients with many lines of treatment. We have 2 patients with a very aggressive clinical course, like survival less than 5 years, and other 2 with a survival that is more close to what is currently the survival for multiple myeloma patients. So we have multiple sites and we run our barcoding. We have also new signatures, platinum, because as you know, sometimes at relapse, we use this PACE or DCEP, this kind of treatment that includes platinum, which no one likes platinum, and apparently neither mutational signatures, because you have these signatures that is platinum. So we have 2 signatures, 2 barcoding for chemo. One is Melphalan and one is platinum. This one is to answer to your question before, how bad is Melphalan at relapse? And that's the answer. You have that 20% of at end stage. So these are patients that are like, they were dead, unfortunately, like relapse to everything. 20% of the mutations on genes. So these are mutations that change protein, non-synonymous mutations. 20% were caused by treatment. Obviously, we don't know how much these mutations are important, but if you see at the baseline, you don't have any mutations, obviously, because these patients don't have any chemo. But at relapse, you have this. So again, we don't know how bad Melphalan can be genomically for the tumor cells. We know that definitely introduce mutations. And for stochastic statistics, you know that a certain number of patients probably get the tumor worse. The question is how many patients you treat and how many patients got worse. We don't know. I personally believe that is more fraction through this mechanism. Then Melphalan has a lot of other problems that we don't discuss today, but I don't see this as something that we have to stop Melphalan, like when lenalidomide was banned because people thought that increased the risk of MDS. So that is a complex figure, but overall, it's just we can represent tumors in the phylogenetic tree. So you have like the trunk. This one is like are the mutations that are shared by all cells. So you have this biopsy in epigastric, this biopsy in left calf, this in inguinal, right lung, liver, gallbladder, all these 8 biopsies. They all share these mutations, and then each site has its own group of mutations. So the length of this color bar is the number of mutations, and each color represents each signatures. So what is really intriguing here is that all but these patients have this gray bar shared by all samples, all sites. And this gray bar is the Melphalan signatures. So if you remember a couple of slides before, is this model. So all cells in different sites, in different acquire at different time, because we are talking about different sites that are not like all at the same time. You know, some progress before, some relapse in the same location, but overall, these 8 different sites share the same group of, I think, 1,000 Melphalan mutations. So which means that all these 8 sites comes from one single cell. And that's kind of a schematic way to repropose this example. You have this chemotherapy, high-dose Melphalan, PACE, platinum, and Melphalan. And as you can see that the platinum, the light blue, is present only in each site, which means that one single cell relapsed in each site. So you have a single cell expansion, because again, if you don't have a single cell expansion, you don't see the chemo signatures. But all these 8 single cells that you see here come from one mother that was one single cell survived to Melphalan. I think this one is a bit too much, but the idea is that having this way to connect, link a treatment in the patient history with a drug and with DNA effect that the drug has on the DNA, we can actually investigate the temporal evolution of these sites. So that patient with 8 biopsies, unfortunately, he died within 5 years. And the progression, last progression, occurred within, I think, 6 months or 8 months. So it means that these different localizations, 8 different sites, were acquired in a short time. So one single cell, in few months, is able to spread all over your body and create these different localizations of metastases. So that's the single cell accelerated model. It's the ability of one single cell survived to Melphalan to spread around and cause these metastases. Not all patients have this model, but this model is completely different from what we know is the progression of multiple myeloma, which is low. You have MGUS, you have smoldering, localizations are acquired over time, you monitor them. So it is like a long, long time. Here it's months. So you have years, decades versus months. So why so? We don't know. Our hypothesis is that the clone may be more aggressive, but also the other effect of Melphalan that no one really cares as far as we understand in clinic is the immune suppression. Everyone that got the transplant or that take care of the patients that got transplant knows that it's not just the 20 days after Melphalan where you recover your counts. You recover your neutrophils, granulocytes, but what about the B cells? What about the T cells? How long do they take to develop? Like a year probably or more. So, and immune suppression, we know it's what cancer likes. Cancer loves immunosuppression because it's something that can unleash all cancer power. So this study, I think it's important because show methodologically, we can use chemo to better understand the cancer evolution. Translationally, we show that Melphalan and platinum are kind of not your best friend. He's a good friend, but you should try to find something better. And finally, there is this immunosuppressed time window that we should definitely more focus on. In particular, still we use transplant because that's probably something that we can act better. And finally, the idea that you have one single cell that leads the progression is fascinating, also because we know that multiple myeloma is patchy. We know that multiple myeloma is not like a leukemia that is spread all over the bone marrow. So you have this, what we call sanctuarium of multiple myeloma, niche. And if we have one single cell, it might be that you have one or two niches survived after treatment. And they might not be in the iliac spine when you do marrow, because, you know, we get the marrow there, but multiple myeloma can be in other place. So you got an MRD negativity, and actually it's not an MRD negativity because you have a marrow in other side. So what we are trying to develop with All4Cure is this immune PET technology, which increases the accuracy to detect these residual lesions in patients with deep response. We're gonna sequence these lesions. We're gonna understand if these lesions are the one that leads to relapse. And why we want to do that? Because if you know that one single niche in your body, let's say sternum, asymptomatic, super small, detectable only with this immunopet, with PET, CT, MRI, it's not a lesion. So you find that is a lesion. You find that this is like the reservoir of multiple myeloma that leads the progression is one single localization. So something that you can attack with radiotherapy. I mean, something that is cheap and you don't need the FDA approval to do that. And a lot of doctors already do this. Like if you have a patient with a very good response and a mild localization, you just irradiate the localization, it is one. So that's the giving a more biological rationale to what people already do or are trying to do in clinical practice. So that's what we are trying to do in the next couple of years. These are all the collaborators that join us in this effort, which is not just a single paper, but there are many, many more. And this is our lab. And with All4Cure, we are together leading this group of fantastic collaborators. And we will keep going. And thanks also to our funders. Without them, we would not move a lot. MSK and our future institutions in Miami. And thank you all for hosting, and I'm happy to discuss and follow up any questions.
Thank you, Francesco. That's really interesting, really fascinating. So just to, so in the cases that you described 4 patients. You found evidence of this accelerated single cell seeding in all 4 cases. Is that correct?
3 out of 4. In the one where we didn't see that is the one where we are sure that the multiple myeloma cells were reinfused. And the reason is that you have a single cell expansion of platinum. It's a bit tricky, but it's nice. So you have the blue, it's platinum. So the fact that you see platinum in each side means that you have a single cell expansion. Because if you don't have chemo barcoding, you don't have single cell expansion. If you have it, it means that you have single cell expansion. So the fact that you have a single cell expansion without Melphalan in a cancer that was exposed to Melphalan, it's kind of a nonsense unless the cell were reinfused. These famous myeloma stem cells that is kind of like the holy grail for multiple myeloma researchers.
Yeah, this might be getting into the weeds too much, but I've never understood why in like some stem cell collection protocols involve exposing the patient to etoposide and platinum ahead of stem cell collection, and I've never really understood why you would do that when you could potentially avoid giving that type of treatment ahead of doing the collection. This is actually
well, now in particular in US with the different health system, most of the patients got plerixafor. In Europe, they are still using cyclophosphamide for many patients. But
yes, and is cyclophosphamide a problem? Do you think that's a problem?
I mean, it's just it's like a chemo, so it's better to not get it, right?
But you don't have a
give any signature.
cyclophosphamide pick. You don't have a. Oh, you do, I guess. Do you have a cyclophosphamide signature? Is cyclophosphamide part of this signature?
No, we don't see any cyclophosphamide. So I guess cyclophosphamide is much safer than multiple myeloma. And I mean, that's a surprise, right? Because cyclophosphamide doesn't kill multiple myeloma.
Mm-hmm.
It's,
Yeah,
it's not an anti-myeloma. It's not like lymphomas where you give cyclophosphamide as an anti-lymphoma treatment. In multiple myeloma, cyclophosphamide is completely useless. I mean, I want to say it's wrong. It's, let's say, in most of the case, it's not effective.
yeah.
But the idea is always the same. So there are a lot of discussions in the community, as always, and that's what makes the community of scientists and clinicians a nice community, because people disagree, and the disagreement brings people to compete, and so discoveries theoretically are pushed, and we can go faster. But one of like a group of people, I don't want to say name, but important people thinks, for example, that there is no real needs for biological investigation in multiple myeloma, because we should look for a pan-myeloma treatment. Like people say, if we DARA, KRD, CAR-T, and the biospecific, we cure everyone. Who cares about biology? And that's kind of reasonable, unless we don't cure everybody. CAR-T, all CAR patients relapse after CAR-T, and so far, once the follow-up is longer, and DARA KRD, it's a fantastic treatment, but again, 30% relapse, and populations are selected. That multiple myeloma with very aggressive disease are usually not included. So what we see in the studies are not always the reality. So I think that this vision is true for some cancer, like promyelocytic leukemia. It's completely cured. I mean, without chemo, they don't, or like there is a New England paper with acute lymphoblastic leukemia with Philadelphia positive that was like a death sentence for elderly patients, 60, 50 years old or more. I mean, they cure 95% without chemo now. There is a New England paper that came out a few days ago from Italian group in a small series. I mean, we are getting there in some tumors, but remember, these tumors are tumors characterized by a couple of drivers. The complexity of multiple myeloma, it's much, much more. It's like a solid cancer. And no one in solid cancer is discussing about a sort of pill to cure all the cancer, all the lung cancer. There are adaptive strategies. There are inhibitors, small molecules. That's where the field goes. And that's where a lot of people are working, like venetoclax for 1114 and MCL1 for 1QK. There are like attempts in multiple myeloma. But at the same time, there are also people that doesn't believe that. It's a long discussion. You can imagine where I am positioned. But the overall idea is that not all multiple myeloma are the same, and we don't have a treatment for all. So you have patients that respond well to Melphalan, patients that don't respond to Melphalan. The Italian group presented a couple of years ago the GMEMA long follow-up at 10 years. So they studied that compared VTD versus TD, thalidomide dexamethasone versus Velcade thalidomide dexamethasone, double transplant, consolidation with 2 VTD or TD, no maintenance. 30% of multiple myeloma patients in the VTD arm, published 2008 Lancet study, are still in remission. So that's just to say that these treatments are toxic, but in some patients provide what we can call long remission, because we don't use cure. As you know, people are afraid of that. But the other question is, can we get the same result with less toxic treatment? That's a good question. That's what people are working on. So I guess the real challenges are get less toxic treatment for patients that can get a longer remission without doing all this thunderstorm treatment. And at the same time, try to get something better from the high risk. And that's where I think the field has a problem, because we don't know the high risk. We don't know how to define them. We are still using categories of 20 years ago that are like a nonsense, in my opinion. So we really need to redefine the high risk. We really need to find what they are and try to find biologically based something different. We can't treat with VRD a super high risk multiple myeloma. We know that it will not work. We already know. So that's no point to enroll these patients in a trial where you know that will not work. In CLL, patients with deletion 17p were not enrolled in the trial with new inhibitors because they already knew that if they failed in the chemo treatment, they would not have benefit. So that's not at the beginning, but after they exclude these patients. That's kind of what I'm talking about. Be reasonable, be smart, based on data, on biological data. And that's what we are doing.
Well, I think just from my, thanks so much for that, Francesco. I'll just say one more thing, and then I'll ask Jane, to turn it over to questions. But, having myeloma myself, having been really pretty darn aggressive in my own treatment, being MRD negative right now. So, and I stay on maintenance, and I've really tried to keep my myeloma suppressed to these undetectable levels. It's almost guaranteed that there are going to be myeloma cells, hunkering down somewhere in my body, kind of waiting for the opportunity to come back and cause me problems someday. And the whole idea that you've created here that, there could be one spot, it might be in my big toe, where there are myeloma cells waiting to come back, and that the idea that you could irradiate that area, if you knew where they were, if I could find them, if I knew what they were, I would do something about it. But with the very best available technology, there's no way of knowing that. Now, you've described an imaging technique that I'm not familiar with, but it sounds like a super sensitive technique for trying to detect these tiny traces of deposits that you could go after then and buy. I think that sounds fascinating. So I've learned a lot.
It's gonna take some time. We will apply to a federal grant next year, which means that if you're awarded is 2022, which means that 5 years research. So it's gonna take a while to prove it, but.
And that's the issue that patients, that's the issue that patients like me face is, there are all of these incredibly exciting developments, but we have to make decisions based on the best available information that's available now. And, in 10 years, we'll all be way smarter, but that's not, that doesn't help. Somebody has to figure out what they're going to do with their.
Yeah, I mean, I agree. For patients now, you don't care of what's going to be approved by FDA in 5 years because you need it now. And I can't be more agree. Yeah. At the same time, the history of medicine teach us, also recent history, that if you design good drugs in a bad way or without a good knowledge of the disease, your drug may be delayed and patients may die.
You bet.
Because your drug is not available. And venetoclax with the Bellini, it's kind of a clear example of how greed and the no science-based decision affect patients, because now venetoclax probably would have been approved if the trial had been designed for 11-14. They wanted to do for everyone to get more, and now no one has venetoclax. Yeah. So that's what I'm talking about. They ignore the science, they ignore the biology, and now patients have to wait, I don't know how long, to get venetoclax approved.
Right.
So that's terrible. That's tragic. And I mean, venetoclax is a drug that works well in a small fraction of patients, but you would imagine if it was a larger fraction.
Yeah. No, I agree.
We have some questions from Facebook. So the first question is from Bonnie. She asks, is the statement that multiple myeloma is in the middle of the mutational spectrum true for newly diagnosed versus relapse?
Yeah. I mean, as you know, most of the tumor samples, solid cancers, are treated with platinum. So they actually at relapse got more mutations than multiple myeloma because platinum has a stronger mutagenic impact than Melphalan. and also like 5-fluorocycline, and there are also other treatments that introduce temozolomide, they introduce a lot of mutations. So the acquisition of mutation at relapse is kind of, you want to say, inevitable when you use a certain chemo. The multiple myeloma is, I think, among the most frequent hematological cancers, genomically speaking, DNA level, the most complex, and the one with the highest number of mutations among hematological cancers, and with the highest complexity for structural events like chromosome shattered, lost, deletion. That's a fair statement. Then obviously you have a rare hematological cancer, super complex, but these are like super rare. Among the most frequent, multiple myeloma is far the more complex. And in fact, people used to define multiple myeloma as sort of like connection between hematological cancer and solid cancer, because it has a lot of features similar to solid cancer. The patchy distribution, the lytic lesions. There are a lot of features that resemble solid cancer.
And Francesco, in the graph that you showed comparing different tumors, was that all for newly diagnosed tumors?
Oh,
those
yeah,
weren't relapse.
Those are mixed.
Oh, mixed.
Also, but also the solid cancers are mixed. So obviously, it might move a bit on the left, on the right, according to which samples you include. But overall, I think it's a fair statement that multiple myeloma is in the middle between super complex and super simple cancers. And again, super simple doesn't mean that they're good. So acute myeloid leukemia, genomically, is one of the simplest cancers, and is one of the cancers with the less number of mutations. It has almost 10 times less mutations than multiple myeloma. But it's the only cancer where you don't have any new treatment before this year in the last 30 years. And patients still, it's like a sort of eating the wall. So there are other mechanisms in cancer. It's not just DNA. I'm working on DNA. So after today, you might think that DNA is cool. I hope so. But there are also other cool or interesting alterations that can be druggable. So it's not only DNA to find it.
We have another question from Dana. She asks, so the initial cell mutations happened years and years before the actual diagnosis. With this in mind, should people be routinely tested earlier in life?
Yeah, that's a great question. So it's actually the area of multiple myeloma that I'm investing more. Because we know that multiple myeloma has MGUS and smoldering before. And there are two studies, one from Ola Langren and CI, and one from Mayo Clinic, Professor Raj Kumar, where they show that if you use a different technology than the electrophoresis, you can actually detect the MGUS clone up to 10 years before the actual MGUS. So let's say people say that MGUS takes 10 years to develop to multiple myeloma. So using a mass spec, this like protein deep technology, you can actually identify 20 years before. And our estimate saying that even before that, you probably have something or you acquire something. And there are a lot of papers published in the last 2 years on normal tissue, colorectal, liver, lung, skin, where you have these clones that are not tumor, but they have mutations like tumor. You have a T53 mutation in your skin, a KRAS mutation in your liver, but these are, or like a deletion, these are not tumor, these are normal cells. So again, the differentiation between what is a real precursor and what is a tumor to be is the key. If we know which MGUS will progress, you can actually do a screening, detect these patients, and treat them before they get MYC translocations, KRAS, and other alterations that make this worse. So your chance of eradication is going to be higher. So that's what we like. I think that's what cancer research should mostly focus on, is preventing, treating earlier without waiting. Sometimes when you wait, when you have a lytic lesion, your cancer is there, your subclinical diversification is there, and the ability to eradicate the disease are low. If you get the same disease 5 years before without lytic lesion, you are younger, you don't have pain, you don't have surgery, you don't have, your kidney are perfect, you can get a better treatment, you can tolerate it better, you can eradicate the disease. you can get less complication. So, but obviously you want to be sure who you're gonna treat. We can't treat everybody because that's gonna be like unethical. It's not sustainable. And if someone doesn't need treatment, you don't want to treat them. But yes, the question is, we are working on that because we want to recognize which MGUS needs to be treated. But we still have to work on that because it's difficult. MGUS don't do bone marrow, so it's difficult to collect material in the first place. It's difficult to get consent. It's difficult to follow up these patients because you have a 40-year-old patients in US, the chance that it's gonna live in your town forever is low because people change place, change town, change hospital, change doctor. So there are some efforts like the PROMIS study, the Icelandic study, aim to screen this, but again, you don't just need to screen, you also need to understand the biology with the right technology. And that's, I think, where these two studies have some problems because I don't think they're using the right technology, but that's kind of my personal opinion. And I personally really like what they're doing, but I think that's not gonna be the definitive study.
Okay. We have another question from Adrian. Is there an argument not to expose patients to Melphalan or stem cell transplant?
So there is, but not based on my data. So our data just say that you can get more mutations, and it's something that people should not be surprised, particularly doctors, because we know that increase the risk of MDS, we know that increase the risk of solid cancer. So this increased risk of tumors must come from somewhere. And increase of mutation is the most reasonable and likely explanation together with immunosuppression. So the anti-transplant myeloma movement that as Ola Langren is one of the main fighters is working on there is always a bit of provocation and reality. So provocative, they say we don't want to transplant anyone anymore. Practically, what they're saying is we don't want to transplant patients with MRD negativity, in particular if it's sustained. And if you get MRD negativity with 80% of patients, like Ola Langren Manhattan trial or the master trial from Luciano Costa with DARA KRD, I mean, it's just probably it's not going to be 80% because the real life is going to be 60, but I mean, 60% of patients below 65 that can avoid transplant and can reach a long PFS, I mean, was not thinkable like 5 years ago. So I think the decision for transplant should be based on today on this. Then now with Ola Langren, we are studying which kind of biology underlying the fact that some patients get MRD negativity and some patients no. Or like the residual population, why these cells survived, what they have, what happened, why we are not able to kill these few hundred cells. And so that's area where we are like, pushing, we are sequencing, hopefully we will have some data end of next year.
That sounds great.
Okay. We have another question from Judy. She wants to know about the effects of treatment-related immunosuppression and if it's still an issue of maintenance treatment.
So I don't think, again, our study should be integrated with a population only 4 cases. So statistically speaking, it's nothing. So you cannot really claim anything from this. What you can claim is the proof of principle to validate this observation in a larger studies. Saying that, the immunosuppression, the fact that it's bad, is kind of known, and Nobel Prize has been awarded in medicine with immunotherapy, which is just reactivate the immune system when the immune system was immune suppressed. Cancer immunosuppressed, so myeloma cells create immunosuppression in their environment. This is why the immune system doesn't kill multiple myeloma, because multiple myeloma immunosuppress the environment. The T cells, B cells, they are not getting there. They don't even enter where multiple myeloma is. So it's like toxic for them. So, or if they enter, they are not able to activate. So the immune system and multiple myeloma has also a strange relationship because multiple myeloma is the only cancer where PD-1 inhibitors doesn't work. It's like in no patients, like zero. It's kind of in every cancer you have like 10, 5, 20%. Multiple myeloma is zero. So there are something interesting going on there. But yes, the immunosuppression is not good. And again, it's what we have. If we have better treatment that does immunosuppress, it's obviously better. But right now, I don't see any real alternative based on the idea that you are immunosuppressed. You just need to protect yourself with the medications that doctors provide, like antiviral, Bactrim, and these kind of procedures. And maintenance probably help somehow because we know that it's kind of immunomodulatory, so it probably helps somehow the T cells to protect better and to contain. That might be one of the explanations why maintenance works. But overall, is an area of investigation. So again, this paper should be seen as something that opens up some new avenue, probably that people never thought about or didn't have like a chance to work on it. So we will try, and we may fail because we never know in science. But I think that immune system and multiple myeloma have a weird relationship that might be unique, as many things in multiple myeloma compared to other cancers. And if we are able to crack it, it's going to be a huge success for developing treatments and to be more like smarter. So the idea is we do science to be smarter in our treatment. We don't want to end up with another Bellini.
Well, thank you.
And we have
maybe one
more question. Yeah. Michelle asks if there is no difference between OS between stem cell transplant versus no stem cell transplant, why take the risk of taking Melphalan and developing super aggressive clones?
Yes, that's a great point. And that's I think this question is part of a big confusion between scientists and clinicians in what is the end point in a clinical trial or in a study. So in multiple myeloma, 20 years ago, survival was a good endpoint because the survival was less than 5 years. So you actually could see differences pretty soon between a treatment and another treatment, like experimental treatment and standard. Now, we know that the median overall survival for a newly diagnosed multiple myeloma patients can be 7-10 years. It's always difficult to understand because there are so many drugs and so many treatments developing that we say today 7 and tomorrow maybe 8 and the day after tomorrow 9. So I think that it's too long to make a study. So you need too many patients. It's like a statistical problem. If you base your treatment on survival only, you need more patients in your trial. You need more follow-up, which means that carfilzomib or daratumumab would have been approved 2, 3, 4 years later compared to what they are approved, were approved. So the point is shared interest from company, FDA, and doctors to accelerate the development. So we look for surrogate of overall survival. We know that patients that progress earlier go worse. We know that patients that are refractory, it's really bad. Patients with sustained MRD negativity are really good. So like there are trials now that base the statistical design of MRD, not even progression-free survival on MRD. So that's to help the community of patients, clinicians to develop drugs and to improve the treatment. We don't want to wait 10 years to show that Velcade is better in survival. And some drugs might never see the survival, like maintenance with lenalidomide has never shown survival in any study, only one, but not in the other two. So the decision between transplant and no transplant based on the PFS, if you look like the French study with Dana-Farber, it's a great phase 3 trial. And they show that there is this difference, but at the same time, they also show if you're MRD negative, there is no difference So I think that's the main message. It's expected that with the VRD induction, with only 4 or 3 VRD cycle and transplant, patients without MRD negativity will relapse earlier because it's not like a DARA KRD or a KRD 8 cycle. It's like not so intense. At the same time, what is really interesting from that trial is the MRD negativity. Patients with MRD negativity, with and without transplant, have the same outcome. So that's where we want to work. That's a really good endpoint where we can define our strategy. We can decide people are working on stopping maintenance when you have MRD negativity, like Luciano Costa and others in Chicago are working on this. And there are people working on don't do transplant, like Ola Langren, if you are MRD negative, and not just him. So that's, I think, it's where the field is, the good field is going. And then obviously there are people that doesn't care about MRD. But I think that, every time that you have an advances, you have always people that say that is not important. Like when they develop locomotive, people used to say that carriage were faster between Paris and Lyon. But I mean, yeah, there is always someone against. But I think that for the MRD and to take important decision on patients' life, we need this, and we need also biology, because if you know that the patient is a very high risk, not all MRD positive are the same, not all MRD negativity are the same. The way in which we test MRD is different. You can test with imaging. This immunopet is a new way. There are liquid biopsy. There are so many new technology under development. So there is no easy answer, unfortunately, in cancer, and in particular multiple myeloma. But there are a lot of interesting way to address complicated questions.
Well, Francesco, thank you so very much for joining us, for presenting your work. Thank you for your work, and thank you for your time and your extremely interesting and insightful presentation. I learned a ton.
Thank you for inviting me.
So much. Yeah, well, it's just been great. Yeah, thank you.
Thank you.
Thanks everyone for joining us.
Have a good day. Bye-bye.
Take care. Bye-bye. Francesco, really terrific. Thanks so much.